I'm David Matthews, and I have great pleasure in introducing this European Diabetes Forum Symposium at the EASD annual meeting. And wherever you are in the world, if you're looking at this live or catching up later, you're very welcome. I've got a wonderful cast of speakers lined up for you this morning. And the first thing I'd like to do is just to introduce what the EUDF Symposium is going to be about. So diabetes is one of the most widespread health conditions in Europe and indeed the world. And if we take the European mainland, 1 in 10 or around 60 million people with diabetes in Europe. And this is going to increase to a population of about 66 million by 2030. And the little map on the side showing 60 and 66 million people, just to give you an idea of what that number means, is that the population of Germany is 83 million, of France 67 million. And then if you put all the people with diabetes in a separate country, they would be the third largest country in the whole of the EU. And that's the size of the problem. So we really have got a problem ahead of us. Next slide. So in 2019, the total diabetes-related cost to Europe's healthcare system was 148 billion euros. And that makes up an estimated 9% of the total health expenditure. And that'll go up to about 12% in the next 25 years. And the majority of that is due to avoidable complications. So we spend about a quarter of that budget on treatments of various sorts, and 3/4 of the budget we spent on all of those things like myocardial infarction and renal failure and amputations and all the other things that go wrong with diabetes. Next. So the idea of the forum is that we can reimagine how diabetes care is delivered, and we can work together to make its diagnosis, treatment, and management better. And the way that we're doing that is to bring together stakeholders from all around the care sector and indeed the patient sector. We're going to be aligning on priorities and urgencies. We're going to try and speak with one voice and achieve some policy results. And if we can take this long-term view of the condition, we can improve the lives of people living with diabetes. So the European Diabetes Forum is trying to pull all of these different people together to give us an integrated, honest, and indeed global view of what's together. So by speaking together, we've got a whole collection of member organizations, the European Association for the Study of Diabetes, EFSD, that's the European Fund for the Study of Diabetes, FEND, which is the Foundation of European Nurses in Diabetes, JDRF representing type 1 diabetes and the younger people with diabetes, the International Diabetes Federation in Europe, the Society Francophone of Diabetes, PCDE, that's the Primary Care Diabetes for Europe, and ISPAD, which is the International Society for Pediatric and Adolescent Diabetes. All of these coming together with supporting collaborators of FPO, which is the European Federation of Pharmaceutical Companies, and MedTech Europe, which again is looking at the technology side of things, together with patients and many other people who have voices both in the political and indeed in the medical world. So we hope to pull all of these people together so that we have both an academic and an industrial input, we have political awareness, and together we can really make a difference. And that's what we're all about. We have already had several forums, and we've come up with these particular points that we are going to focus on directly initially. And that's about data registries, it's about self-care technology and digitalization, and it's about integrated care. And by working on these particular silos for the start, we can start to manufacture a united voice about all of these different aspects. Now, we're not limited to these aspects. It's just that this is where we feel that we can start. It's important to recognize that talking about these things is not what we're aiming to do. What we're aiming to do is to change things, change society, change opinions, and indeed improve healthcare for people with diabetes. So we can unlock the full potential of health data. We can define, track, measure, improve outcomes in diabetes. We can measure and compare diabetes outcomes across countries, and we can look at causes of variation, which helps to highlight areas where better outcomes and efficiency gains can be achieved. And establishing the infrastructure to collect and analyze health data scattered across the health systems, as well as securing the political aspects, will apply to learnings from outcome data. And so these are the patient-reported measures. So here's the agenda, and I'm not going to read this to you, but we'll let it unfold because I don't want to spend too much time when we've got such good speakers. So let's just move directly to the first aspects that we're going to be looking at, which is about how can we use data to raise awareness and initiate action. And we've got 5 wonderful speakers here lined up to talk to this. And the first lecture, I haven't said hello to Bente yet, but I hope she's there, is from Bente Mikkelsen, who's the Global Director of NCD. Oh, Bente, welcome. She's the Global Director of the NCD at the World Health Organization. She's had a very long history in NCD, that's non-communicable disease, with the WHO and with Europe. She's herself a trained gynecologist and has been working across sectors with many stakeholders. And so there's nobody better on the planet, as far as I can see, to give us a keynote than Bente Mikkelsen. And over to you, Bente. Welcome, and the floor is yours.
Thank you very much, David. Can you hear me well?
I can.
Oh, that's excellent. So it's such a pleasure to be here. And actually, I stepped out of our first meeting on the Technical Advisory Group for Diabetes is just meeting today with the chair, Amanda Adler, and she sends her regards as well. So I will develop a little bit on developing missing targets, and I'm so happy about your perspective of data-driven action. That's exactly what we need. Next slide, please. So I guess it's almost useless going through all the 10 reasons to focus on diabetes, but actually this list were the one that made the 194 member states of WHO this May during the World Health Assembly decide on a resolution on diabetes. And that was on time. So as you have already spoken to is the growing diabetes epidemic. And of course, I focus on the global level. And as you can see, we have very, very alarming prospects with an estimate of 700 million to 2045 if we are not changing the way we do business. And of course, of great concern is that this is the only non-communicable disease that is actually increasing in premature mortality, so much as 5% since year 2000, so meaning dying before 70 years of age. And there are many reasons, of course, but one of the really alarming as well is the insufficient prevention and obesity raising with 150% since year 2000. So lack of diagnosis and treatment, you know this, lack of access to medicines and technology. Globally, we know that 50% of people with type 2 diabetes who need insulin don't get what they need. And this is 100 years after the discovery of insulin. And of course, lack of access to primary health care, not included in UHC, and one of the drivers for poverty in the world, with a lot of out-of-pocket payment for the single person if they can access insulin and also devices for diabetes. And you have already mentioned the COVID-19, and we saw already in May 2020 that around 50% of the countries reported huge disruption of services to treat diabetes, but also its complications, also including, doing the diagnosis. So these were among the main reasons why we believed as WHO that a new resolution was needed. So what happened was that the member state built on the commitments they already made, and they have already committed to cover 1 billion more people by 2023 with quality essential health services and covering all people by 2030. So this was the UHC resolution happening in New York. Also, they have already committed to strengthen efforts to address NCD, including NCD as part of UHC, and to minimize the impact of the main risk factors of NCD. So this was happening before. So what happened in May, and you see here the picture of Dr. Tedros, who provides great leadership also to the agenda of diabetes. And he was saying in his final words to the World Health Assembly that he was very happy that we asked the member states to develop pathways to achieve targets for the prevention and control of diabetes and also monitoring and surveillance. So the requests that is made by the member states is manifold. So as you can see, this was one of them. Also considering development targets and recommendations, which we have now developed with the open discussion with everybody online, and it will be discussed in the next executive board meeting in February. So other requests for the Director General from the member state is also to develop guidance for member states for uninterrupted treatment for people living with diabetes in humanitarian emergencies. And I would actually like to quote the president of ICRC, who told me for the first time, and I didn't realize this, that more people have their legs amputated in refugee camps because of lack of insulin than of landmines. So this is also a very important area of focus. Then you will see that there are very specific asks, so things like harmonization of regulatory requirements, also building web-based tools to share information, coming back to data for the transparency of markets, and also to, of course, develop recommendations for adequate and sustained financing of diabetes. And we need to report back to the World Health Assembly. Next slide, please. So, of course, there were lots of discussions about the need for more targets. Some of you will know that already in an NCD Global Action Plan approved in 2015, there are targets speaking to diabetes, and it's even one specific diabetes targets which say that before 2025 there has to be zero growth in diabetes, which of course has not happened. There is also targets about coverage and health system strengthening. But anyhow, we believe that there is a need for more specific targets within the regional global NCD programs and the national programs for health. And of course, one of them is the new commitments made by member states on the coverage for UHC, but it's also very importantly, and we learned this from our consultation with people living with diabetes, that there is a need to address the diabetes treatment gap, but also the gap to control. So even if you are lucky enough to have a diagnosis, and if you have got some treatment, we see that many are still uncovered by the treatment and many more are not controlled. So these gaps are important, and to be able to follow the gaps, there is a need to have targets speaking to them. And this was also the strongest ask from non-state actors, multi-state actors, and also experts. So what has happened since May is that we have worked with a group of experts, and these are the targets that was mentioned in the discussion papers. And thank you for those of you who have inputted to the paper. And you can see that these are global targets. So of course we have member states in Europe that should be overachieving these targets. but this is the assessment of what is an ambitious, but at the same time motivational and reasonable targets. So the targets is 80% of people with diabetes are diagnosed, 80% of people with diagnosed diabetes have good control of glycemia, 80% with diagnosed diabetes have good control of blood pressure, and also 60% of people with diabetes receive statins, and 100% of people with type 1 diabetes have access to insulin and blood glucose self-monitoring. Next slide, please. So for the monitoring of diabetes response, it is recommended to WHO that we need to continue monitoring the risk factor dynamics and country capacity to prevent and control NCDs, including diabetes. So even if we work on the gaps in treatment and control and also access to medicines and technology, we need to have a comprehensive view spanning, of course, from preventional diagnosis towards the end, also to complications. We need to develop a monitoring framework and tool for monitoring the performance of healthcare system through monitoring the process of care and the outcome of the levels of health facilities, and to support the development and maintenance for surveillance systems and promote the use of information and communication technology, as you mentioned as well. So there are existing tools for monitoring, because this is the first question many countries will ask us. Okay, so these targets seems reasonable, but how on earth can we do it? Because we have already so much monitoring ongoing. So when we have assessed this, we have most of the data needed already. Of course, there needs also more development, but it's not a big additional burden. So these are some of the tools. I don't want to take you through all of this, but they span again from prevention through the stepwise survey on the risk factors like physical inactivity, healthy diets, tobacco, alcohol, and also global school-based student surveys to the country capacity surveys. So this is a very dense slide, but it's just telling you that we are soon to deliver the next version of the paper to the executive board, which will then discuss this in February, in February 2022, and it will also go into the World Health Assembly 2022. So I want to also mention the bigger framework of things. So we were very happy to co-host with the government of Canada on the day of the discovery of insulin. So as you can see, there are high-level speakers. We have Dr. Tedros, we have Mayor Bloomberg, we have also the Prime Minister at the time of Norway, and they all came together also with people living with diabetes to really show their huge support for all coming together. And the togetherness is important. WHO will do its bit. We also need, all kind of non-state actors, civil society, and also engagement of the private sector. So the vision of the Global Diabetes Compact is, of course, then to reduce the risk of people, to ensure that people who have diagnosed with diabetes also have equitable, comprehensive, affordable, and quality management. As you know very well, this is not the case today, not even within countries. So you see that it's huge inequities, and of course, again, it's a power dimension. So we have defined a work plan, and we have different work streams. We work with a lot of partners, and we will welcome more partners. We will soon go out with a call for interest to the Global Diabetes Compact Forum, where we hope to meet a lot of you as well. A very important work stream is the access to insulin and associated health technology. So during this year, we have had 2 meetings with the private sector, which we are mandated to do. And at the last meeting, we even got commitments for pre-qualification of insulin from 4 companies, and also pre-qualification for health technologies. And this is a huge step forward. We have had pre-qualifications mechanisms since 2019, and this is the first time we have commitments from the private sector to really utilize this. And this could also be the first step to establish pool procurement, but also the transparency mechanisms that we discussed earlier today. Then, of course, we will continue to provide technical products and normative work, and we hope together with the technical advisory group and with partners to define where the gaps is. We hope to really make a huge step forward when it comes to research and innovation, and it's of course a lot of interest about thermostability, on new kind of devices, new kind of technology, new ways to deliver healthcare services, as we have seen developing during COVID as a mitigation as well. Then together with our colleagues working on health promotion, health literacy, we will try to develop new methodology so it's really happening on the ground. So when we have insulin, when we have medicines, when we have technology in place, we will also have the adherence to the treatment among the people. Then we have already started our country support, and we are of course very eager to see more partners coming on board. We have support from the government of Denmark, government of Norway. We have also the government of Switzerland, but we of course need more people coming on board also to help us to support the countries to implement many of these things. So the next slide, and I'm moving towards the end, but I just wanted to say a little bit more about the access to insulin and health technology. So what we can see is that there is a lot of interest for co-creation and bundle solutions. And there is also now a common agreement that we need to publish the contributions from the private sector. And as you see, I have already mentioned some of them, but we also have very interesting initiatives now to see if we can use the same cold chain integration as we see for the vaccines from the pandemic towards COVID. We need to also build the preparedness for the chronic diseases like diabetes during COVID and tag on to the new innovative work happening there. So the next dialogue is in February 2022. So I think a way to summarize is that we need to unite, and this was a strong message. There's a lot of good work happening on diabetes, but we need to come together. We need to speak with the same voice, and we have to see the same narrative. We need to integrate, we need to innovate, we need to access, we need to cover, to treat, and to build. So the key milestones as we go forward, and as we are now turning into October, November, you can see that we have engaged with regional office, and we will continue to do so in the lead up to the World Diabetes Day. We will celebrate, of course, the World Diabetes Day together with all of you, and then we will have the first Global Diabetes Compact Forum, and today and tomorrow we have met with the TAG. And I think that's what I was able to tell you, but I am so pleased to listen to David in his first intervention. You didn't need me in the meeting, actually. I think you summarized so well, and I think we need now to really utilize the data we have, create the data we need, and action upon them. It's no need to have data that is orphaned. We need to turn that into action on the ground. Thank you so much for having me.
Bente, thank you so much indeed for a brilliant opening lecture and covering so much of this topic. There's no doubt that the WHO are doing huge amount with NCD. Of course, traditionally, many years ago, they had rather focused on communicable diseases, and now really getting a grip on the non-communicable aspects of these chronic diseases, which are so important in the world and which are pulling down populations' health. And indeed prosperity. So thank you so much, Bente, and all power to what it is that you're doing within the World Health Organization.
Thanks a lot.
So now it's a huge pleasure to welcome Robert Heine. Robert and I go back many years. We helped run one of the European Association for Study of Diabetes study groups. And have known each other and enjoyed each other's company over many years. Robert had joined Eli Lilly and was their vice president for global medical affairs until 2014, and is now very much involved in external research collaborations and international medical education. And there's nobody better, in my view, to talk about using data to raise awareness and initiate action to improve diabetes care. The whole question about data is not just collecting it, but keeping it up to date and indeed using it properly. And Robert will be talking expressly about all of these aspects. And Robert, what a delight it is to have you here, and over to you.
Great honor and pleasure to be able to present the preliminary recommendations of the Forum on Data and Registries, and I'm doing it on behalf of the whole working group. And I really first would like to provide a background and a bit of a history on where we are coming from. As we all know, there are a lot of guidelines which have been published, and most of those guidelines are fully aligned on the targets that we need to achieve for glycemic control, blood pressure control, and for lipid control. And these guidelines, as I mentioned, have been around for at least a decade. So it is truly extremely disappointing to see that those guidelines by themselves haven't really established or have contributed to a better care for people with diabetes. And this is taken from a very recent paper in the New England Journal of Medicine, showing that the proportion of patients achieving glycemic targets, blood pressure control, hasn't increased, but has decreased over the last decade. Lipid control has leveled off. And if you really look at the proportion of people with diabetes who are controlled for all risk factors, it's only 1 in 4 or 1 in 5. So these are indeed even below the targets just mentioned by Bente in her presentation. So this really should spur to serious self-reflection, and also leads to the conclusion that we collectively have failed to establish a healthcare system that serves the needs of the many people with diabetes. And listening to just David's introduction, so from these numbers, if it is translatable to the European population, out of the 66 million people with diabetes in Europe, about 50 million do not achieve the treatment targets. So it's a very sad conclusion, but it should spur some self-reflection and also action. What we can conclude is that there's a huge gap between guidelines and clinical practice, and even worse, an even bigger gap between guidelines and the achieved clinical outcomes. And this raises the question, is there a need for new and ambitious declaration of goals, like the one we all worked on with the St. Vincent Declaration? Or should we really make a call to action, concrete action that can change this paradigm? So this is the working group I've been privileged to chair the last year. At the end of the year, we hope to be able to present the final recommendations. And as you can see, all the groups that David just mentioned are very well represented, and I'm very proud of working together with a very distinguished group of scientists and advocacy groups, people with great experience also with registries and data handling. So this was an extremely great pleasure to work together with this distinguished group. So we learned from Massimo Benedetti, so one of the members of the group who already talked about this topic in 2019. And he raised the question, well, why a European diabetes registry? And so the recommendations they presented were about standardization of the indicators for continuous benchmarking, to improve and harmonize diabetes care, to monitor and support European policies on diabetes, and very interestingly, also to respect the law. And it's interesting that already in 2012, so almost 10 years ago, the European Parliament passed a resolution calling for coordination, collection, registration, monitoring, and managing comprehensive epidemiologic data on diabetes and economic data on the direct and indirect cost of diabetes prevention and management. So already in 2012, this was a very important topic, but unfortunately hasn't really been followed by a clear action and to make this work and being established in Europe. So the conclusions of this EUBio network led by Massimo concluded that diabetes information is key to deliver better outcomes for people with diabetes, and a concerted efforts are needed to fulfill the resolution of the EU Parliament and make sure that an optimal diabetes care is equally possible for all citizens of Europe. So this is the backdrop against we started our work, and we didn't only look in Europe for existing registries, but we also expanded our search outside. So an important piece of information was collected in Hong Kong, where Juliana Chen has been leading the integrated care model for more than 2 decades. And for me, this was the key slide, the key figure that really illustrates where the registries should be positioned. So in the reddish box in the middle, you'll find the diabetes register that serves to monitor and to provide the data with which the governance structure of the Hong Kong diabetes model can interpret and also allocate resources and finances to build additional capabilities and capacity to achieve the desired level of treatment for their patients. So they also set a similar target as I mentioned earlier, and added some important other patient-related components in their register. And of course, the input was provided by the physicians and by the non-physician staff, like nurses and educators. But the key message of this figure is the diabetes register is not a nice to have, it is an integral part of the integrated care model. And not just a part, but also the key component of the integrated care model, allowing for accountability and also providing the required information to change care where it's needed in order to achieve better control. Has it resulted in improvement in long-term outcomes? And I think this is quite spectacular. If you look even in the first years following the implementation of this integrated care model, the number of people with coronary heart disease, stroke, heart failure plummeted almost and was reduced by more than 50% over the years after the implementation of this care model. And we are talking here about around 750,000 people living in the area of Hong Kong with diabetes. So this clearly shows that if you take it seriously, if you implement a data registry system, which is an integral part of the healthcare system, you can achieve outcomes if you have a concerted action around these data. So the forum has obviously identified also the key challenges, and I'll start with the key challenges and then I'll jump to the opportunities. So the challenge we identified is how can we apply the information from registries to improve the quality of care? This truly requires the buy-in from all stakeholders. And how can we be bolder? This is something which I also take personally. As David mentioned, we have been in diabetes for a few decades now, and it's very sad to see that there's no real improvement in the way care is delivered. So apparently, diabetes is not heard, and doesn't make enough impact. So a declaration will not be enough, so we need to really be much bolder than that. Primary care physicians are already heavily burdened and are the key players in diabetes care and need to support and drive the data and registry efforts. So how can we do this without putting an additional burden on their plates? And I think that's an important challenge that we need to address. So what are the key opportunities? So there's more the positive way to look at this, this project. Well, we have seen successful examples. If you do it in the correct way, you can really drive improvement in the healthcare system. So I think that should be a huge opportunity we can leverage. Data and registry provide the opportunity to play a bolder role. So if you have the data, then you have a stronger seat at the table because data don't lie. And I think that's something we really need to work towards. And finally, we can also develop strong partnership with healthcare organizations, payers, governments to ensure buy-in for a data-driven care delivery system. And I think that's the key opportunity that we need to establish and leverage. So the key learnings, a registry is not enough, and I'm happy to see that it's in the title of this symposium. Stakeholders buy-in is critical. The diabetes voice is too soft, and we need to step up and we need to amp up our voice in order to be heard. And the steering committee with the required mandate need to implement data-driven changes. So let's review them one by one briefly. Next slide. So in order to make sure that data are translated into action, we need an executive committee, a governance structure comprised of all major stakeholders in the provided care. And this committee should be involved not only in the creation, but also in the maintenance and the governance. This committee needs to ensure the involvement and buy-in from all the stakeholders and also be an integral part of a healthcare system such that the data will drive change in care where it's deemed necessary. Of course, a high-quality registry doesn't come for free, so there needs to be an economic incentive to maintain this registry to make sure that it is sustained over time. And the results and the indicators on the registry should be accessible for learning and research purposes. Engaging the stakeholders in diabetes is obviously key, and this will require a tailored communication strategy in a very in a clear language that's understandable to all the key stakeholders. And this really should appeal to the interest of the different actors in the health ecosystem. And that's the reason why it needs to be tailored. Of course, there are a lot of people who are a bit wary and anxious for registries, so it needs that angst needs to be taken away. For people with diabetes, it will be important to clearly understand that their data will contribute to a better care delivered to them and their fellow people with diabetes. So I think there's important way to communicate the need and also the importance of having a good registry. And of course, they should also have access to the data. In order to reduce the burden on the healthcare system, all data need to be collected automatically. I don't think we can ask people to enter their data manually anymore. And this also should ensure a higher quality of data collection. So for primary care physicians, they need definitely an incentive to participate. And we need also to avoid any open text fields. And we also need to aim It's a longer-term goal to centralize the management of data registries in Europe. But this is a key point, the automatic data collection. Longer-term goal, linking diabetes registries that are well-functioning. This will require some more technology. And one recommendation that was added recently is to establish a unique identifier for patients in order to link different registries. And I think this is a very important recommendation that needs to be explored, but that's possible in Europe. Also, to create one governance framework in order to link the registries, and also in order to make sure that all the data are collected correctly, create a validation mechanism for these different databases. And I come to the end. So these are and I must add to this that these are the preliminary recommendations, because we still have a few meetings to go before we are going to do the final write-up of all these recommendations. It really comes down to proper governance, engaging the stakeholders, automatic data collection, and linking the diabetes registries. And with this, I really would like to once again thank the working group that did a phenomenal job in supporting and formulating these recommendations. And I really would like to thank you for your attention and looking forward to the discussion. Thank you so much.
Thanks so much, Robert. A brilliant overview of all of the problems related to registries, but actually also the wonderful illustration from Hong Kong of how such proper collection of data can really influence healthcare in a dramatic way. And if you looked at the financing of the savings of that, it will be absolutely extraordinary. So I think that's a really good indicator. It's now a great pleasure to introduce Andre Rees, and he's the medical director who's become the Director of Public Health and Risk Assessment at the European Union. He's the Director General for Health and Consumers there, and he is going to be talking to us about how to reuse health data for the benefit of public health research and innovation. So a delight to have you talking to us, Andre, and over to you.
Thank you and welcome everybody. I'm very sorry that I couldn't get through the stormy weather in Brussels. Something is wrong with the connectivity today after storm we just had 1 hour ago. And the time I was given, I will try to go through a number of slides which we prepare for you to share, because I think it's important to see where we stand with the European health data space and how this link to diabetes registries and the whole work in the field of public health, but also R&D. So this is the concept we believe we really should bring digital health to the 21st century as ambition. When we say digital health, we mean also digital data. And I think what Robert said, I can only fully subscribe, that the automatization, digitalization is the only way we can increase the quality and access to data. But of course, at the same time, we have a number of challenges ahead of us. So, of course, your community is quite essential for our discussion. We try to connect to all communities, somehow, bringing together to this space, European space, as many groups as possible. So I'm very happy to have a chance to share some thoughts with you today. So the aim of your organization is also highly in our agenda, so I don't need to remind you, but this is, I think, all what we understood also reading your commitments. And finally, how to make patients, actionable to the data portability, because this is maybe something I can explain later in my presentation. So we are in the kind of two different modes, if I may say. In one hand, we have the concept of primary health data. So basically, we would like to increase access, but at the same time, increase security of those data. But on the other hand, we have the secondary health data, which we believe they should be more accessible and to be used by as many important parties as possible. Connectivity, of course, depends, of course, on the number of issues, including the quality of registries, but mainly electronic health records, which we very strongly support, the way how accessible medical devices and also smartphones and other IT devices are. And finally, how patients or physicians, healthcare providers are active in providing those data into the space, but also research community. How to identify the citizens and health providers, and how to bring reliable data to this space. And finally, big job, how to coordinate on the European level. So when we go to the number of challenges we are facing when we analyze the situation, we try to put them as you see, in 4 columns. So issue around legal concept and governance, the quality of data, infrastructure, but also capacity building. All these things has to be bring together. And then on horizontal part, we would like to get better healthcare, better policy making, but also better research and innovations. So for us, they are not competing goals; they are on the same string. So let's see how. I'm not going to details. The slide will be shared after the meeting. Next slide, please. So here we the concept of primary healthcare data and the reuse of health data. So here, where we are now, there is the patients, by law, by number of court decisions, but also ethical concerns, has access to the data, but the access to those data is often very limited for a number of reasons. But even worse, the interoperability of different sources of data, this is really quite challenging, on all levels of healthcare today. Not just European, but local and regional. So we like to help patients to control better their data, increase interoperability, find the role for so-called e-health agencies, which are set up in most of member states. Reinforce, the European system. I don't know you are familiar, but we have the group of member states in so-called e-health network, which is able to decide, number of issues. But in the current system, so-called Article 14, Directive of Patient Rights for Cross-border Healthcare, this is a collaborative instrument. We'd like to make this more operational. And finally, reinforce, the system we are building since a number of years called myhealth.eu. So now we have 7 member states on action. We hope in the beginning of next year to get to 15, and next years the rest. The issue on single market, they are about services, how to move, services, digital products across borders. And this is, of course, a challenging exercise as well, because we have many new ideas, many new products, technologies supporting our work as physicians, but also helping patients. But we need to employ them in our area as well. On the other hand, we have the health data to be used, in secondary use, and here we would like to make sure that the governance rules are helping, and we can facilitate by digital infrastructure, legal framework as well. There are problems here as well. We're also looking for AI as an option, but this is something we may discuss later. So in the framework, we are in the kind of 2 streams of work. One is related to the cross-border healthcare directive, which is already since 2011, but formally was executed in most member states by 2013. And this is the place when we have number of legal tools, but they are also somehow limited. We have new approach in the data privacy, which is known as a GDPR, quite important act, which we would like also to interact properly. Data Governance Act, important part of our work concerning the whole data spaces and the way data should be available to different type of data. So this is the kind of framework of all those data. And finally, Artificial Intelligence Act, which also is tackling the kind of framework for AI regulation. And here we have European Data Space, which is a smaller part of this bigger bubble, but also with number of specific issues, which is why it's out of the blue. So next, please. So here we are. I'd like to explain how we believe the data should be used for healthcare. So now when citizens are moving, between the countries, they will be able to get those data, between the countries. We are donating data, but the data should be interoperable and of course in digital format, and also portable. Next slide, please. So there are principles we like to get into the system, so access to data in digital format, interoperability, and finally tools and infrastructure, including the apps, the access to smartphones and to the personal data space, and of course, availability of patients to provide data to the providers if the healthcare providers in other country would like to, or if their own country would like to get it. So here where we are with the building, I said that we have 7 member states already in the system, more coming in 2022 and 2027. And here there are the number of activities which are kind of set up, patient summaries is updated, and this is quite important. E-prescription is working already. We are working on lab results, medical images, and discharge letters. And all these things, when they move from one country to others, they also are available in the language of the doctors. Basically, patients traveling from Finland to Estonia, his patient summary, or also future the health record can be translated into Estonian in Estonia, or in Polish when he's treated in Poland. Next slide, please. So this is about primary use of data. Again, the concept we have on My Health, and I will try to finish in 1 minute. And secondary use data. Next slide, please. Here, we would like to bring, as I said in the beginning of my presentation, as many parties as possible. But it's very important that we all should contribute to this project or to this data space, but also have access. So, I'll give you an example. European Medicine Agency can do much faster job, for example, in the pharmacovigilance field, or in the assessment of medicines after marketing authorization. So this is the way we like to connect to the national nodes. So this will be here the kind of control nodes, allowing each member state to control and somehow privilege parties like European Medicine Agency or European Center for Disease Control, but also on the other parts we have number of already networks they are connecting to the system in the future. So of course we would like to introduce, in the kind of framework and establish the rules and procedures, interoperability and data quality, and of course give the legal base for the reuse of health data and increase the kind of transparency in the system. And I think would be the last slide. So this is about also the way we like to bring some modern tools into the field. So I hope we will see this in next year or two already available and helping with travel and access to a number of digital tools for the European citizens. Thank you.
Well, thank you so much, Andre, for that overview. There are clearly quite a lot of problems ahead, trying to integrate across countries and trying to get health data around the GDPR regulations and so on. So I'm pleased that there's a commission that's looking at all of this within Europe, and we wish you every success in pursuing all of those aspects. So thank you very much indeed, Andre. Wonderful. We move now to away slightly from the really sharp problem of children with diabetes. And we're very pleased to have two speakers about this, Thomas Dane, who set up the SWEET project, and Katarina Olofsson from Gothenburg. And we're going to hear, first of all, about from Thomas, about best practice using registries to improve quality of care outcomes, especially related to children. So, Thomas, thank you very much indeed.
Using registries can help to improve quality of outcomes. The first slide, the next one, please, shows you that just having a registry is not enough. You see, I think, well-to-do countries amongst Europe and also across the Atlantic who have registries, but nevertheless, although the age-dependent rise of A1C is very, very similar, the level of A1C is quite different in these countries, and all of them have registries. So registries alone doesn't do it. So what was our idea? And the next slide shows you what the excellent work from the European Union actually has started way back then in 2008, when they said, well, we need to do something. We visited the European Parliament, showed them how technology, diabetes technology, may change the way that children with diabetes are treated. And they said, yes, we will support a program to develop centers of reference for pediatric diabetes. And now, nearly 12, 13 years after this initial time, I can show you what has happened. It was our vision to have equal high-quality care for children with diabetes. And in achieving that, the mission was to harmonize care, to optimize outcomes in children and adolescents with diabetes, first within Europe and meanwhile worldwide. The next slide shows you how this all has started. So it was part of the EU Public Health Program in 2006, and we agreed not only to have a registry that was based on the standards of care which were put forward by the International Society for Pediatric and Adolescent Diabetes, which is part of this EUDF forum, but not only to collect data, but also have a peer review, audit, and regular quality control circles to improve care. The next slide shows you how it has developed now. It's a worldwide registry, has more than 140 centers around the world, but the next slide shows you that actually in Europe, we still have the majority of the centers, and obviously we are trying to harmonize it in Europe, but also beyond. The next slide shows you how we were able to analyze from this very, very beginning, not only in Europe, but also abroad, 22 centers that have been there in 2008 and 2018. What has happened since? And this was published recently in Diabetes Technology and Therapeutics. The next slide shows you comparing it to the Type 1 Diabetes Exchange in the US. And you see that, yes, there is a difference still between registries, but the good news is that Sweden was able to improve in every age group the average A1C in these 10 years. And this was actually happening in 21 out of 22 of these centers. The next slide shows you And please recognize that this is, of course, real-world data. It's not a controlled trial, so it's difficult to judge how much these things are actually just a coincidence or whether it's really the cause that led to change. But it is apparent. If you look at the yellow bars, those are the patients who are meeting the treatment goal of an A1C below 7%. And it appears that, for example, the use of diabetes technology, which is diabetes pumps, insulin pumps, which is the brown bars, which is actually rising before actually there's an improvement in A1C, in the percentage of A1C seen. And there's even another rise of CGM, again, preceding another improvement in target achievement. So, well, we don't exactly know whether technology does really lead to the change, but it is at least pointing in this direction. The next slide shows you how we are doing it to really improve our control and how to make these judgments. You see a benchmark, which is, of course, far too small for you to judge, but it shows the different parameters. It shows you whether or not the data completeness is achieved, because only if you really collect longitudinal data of good quality, then you're able to really make a good judgment. You see it's different in different parameters, so this is a very important part of it. It looks as if we have less patients, but please realize this is the first upload in 2021. The second upload, of course, will appear later this year, so the number of patients will increase. But overall, we can see that data completeness over time with such a dashboard is improving. The next slide shows you also that such a registry helps you to look at the rapidly changing way that we're looking at glycemic control. There's a lot of talk at the current EASD how diabetes technology will change the future of diabetes, that maybe even the A1C at some time might no longer only complement the continuous glucose monitoring data, but maybe even continuous glucose monitoring will become the standard. And you can see here when we are calculating the combined glucose indicator from the continuous glucose monitoring data of those centers who have data on this, you see that the median A1C is just the same whether it's measured or actually calculated in 26,000 children with diabetes worldwide. And even if we take the average A1C in all of those, whether they have CGM or not, we come to a very, very similar median A1C, showing you how diabetes technology may change our way of looking at it in the future. The next slide shows you how important it is really to not only to compare yourself with other centers to see what are they doing better, where am I doing pretty good, where can I learn something from somebody else, and where maybe I could serve as an example for another center, but also as we are getting better sometimes, but also getting worse sometimes, it's important also to look at the trend in your own center to see whether the ideas, the changes that you have undergone are actually successful or not. The next slide shows you that size doesn't necessarily matter. And you see the size of these dots is the amount of patients that are treated in an individual center. And so you can see, yes, we have big centers, we have low centers, at least 50 patients needed to be submitted to be part of this picture here. But if you click once more, obviously, if you have your center on the left side, you want to go down to the right side to have more patients in pretty good control. And so this gives you a chance to look at a center of a similar size, which may face similar problems as you are in your center. So the next slide shows you what is the uniqueness, I think, of the SWEET initiative. It's not only delivering the data, but also be part of a peer review. So in order to become a center of reference, you have to fulfill the criteria put forward by our scientific society, ISPAD, But then you are visited either in person, that was before COVID, and now we're implementing virtual peer review to alleviate all the problems that we have traveling right now. So that the center is looked at, and we're actually learning from each center what is really working very, very well in the center, what can be done better. And this also helps the centers, of course, to collect data, to deliver care in the best possible way. The next slide shows you COVID. And because it was mentioned many times, of course, that COVID is a big thing, and registries may help us to get an idea what really happened. And we looked into, we divided our SWEDE registry in quartiles of background mortality. So the highest mortality would be quartile number 4 on the right side: Belgium, Chile, England, France, Ireland, Italy, Netherlands, Spain, Sweden, and USA, which were hit particularly hard during the first lockdown, the first wave. And the next slide shows you what happened to the children with diabetes. And if you click once more, you see on the right side, the major impact was in DKA, also DKA and follow-up. So as a sign of the interruption of care, the rate of DKA was increased significantly only in this quartile with the highest COVID burden. But the good news was immediately prior the second wave, so after the first wave, it was back to the baseline levels, showing that, yes, it was just a short period, and hopefully, if we look at the future waves, this immediate negative impact with the rise in DKA will not happen. But the good news is also on the left side of this slide, you see the A1C on average remained the same. And the next slide now shows you there and if you click once more, one really very interesting thing that the insulin pumps didn't change. Obviously, it takes a lot to start people to onboard them on pumps, but it also takes a lot onboarding on CGM. But CGM really increased significantly after the first wave. There was a big difference, so people understood with COVID how important CGM is, and in all quartiles of COVID burden, there was a significant increase of CGM use in children to manage diabetes. So really technology, if we look at the next slide, really appears to help with better outcomes. You can see that here, looking at the whole group of SWEDE participants, the best results in terms of A1C, in terms of DKA and hypoglycemia is if you use diabetes technology. But it's not technology alone. And the next slide shows you how important it is to have targets. You need ambitious targets, and those centers who had the most ambitious targets appear to be also those who are reaching the best average glycemic control. And of note, there was no association between the education time or the full time employment of personnel and A1C. So it really appears that targets and treatment philosophy in those centers is so important. And it may be a little bit of a comfort for those centers who feel, well, all I need is a lot of money, a lot of technology, and a lot of personnel. No, I think it is really the multidisciplinary team and the cohesion in the team, and that everybody speaks with one voice. And this is something of learning beyond the SWEDE registry. The next slide shows you now something also which may be misleading if you just look at registry data without knowing what is happening behind. Because if we look here at the long run, at the risk factors for complications, you might have the impression that nephropathy is rising in SWEDE despite the better control. Well, this is clearly ascertainment bias, because we are really trying to improve our data, particularly also with the long-term data. And this is why we are capturing nephropathy better and better. And this looks as if nephropathy would be actually in the rise, although if we look a little bit closer, I'm pretty sure it is in the decline. But this shows you that registry always needed to be interpreted in the whole field of the background care. So what are now my take-home messages? we need to include the patients. And this is really the next step. We have done great initiatives of trying to involve patients, but we really need to get the patient voice into our registry much more. We are in the process of creating a patient advisory board and trying to collect the patient-related outcome measures, which is, of course, worldwide with GDPR, not an easy task, but we are very optimistic that we find a good way of doing so. And so to finalize all that, if we look what should be used from the learnings from the SWEDE registry by the decisions makers, I think we have good evidence that registries are effective, but we need to ensure the sustainability. Too many registries have appeared and then disappeared as financing dwindled out. We hope that the future advocacy will point in the direction that it's important to sustain the existing initiatives and join them instead of creating new registries which have a short life. And finally, the big hope is, of course, that the use of this data will be to translate it into healthcare interventions with the involvement of people of diabetes to really make a huge impact beyond the actual registry. And so I thank you very, very much for your attention, showing you that we are growing, whether it is in person or the next and final slide or virtual like this EASD meeting. Thank you very much.
Thanks so much, Thomas, for that great overview and demonstrating to us how important it is to have clear data available for children and young people, and indeed that having such data demonstrates that you can improve care. Now it's a great pleasure also to have Katarina Ulfsson from Gothenburg. She is the director of the Swedish National Diabetes Register, and Sweden has always led the way in registries. I remember over many years recognizing that Sweden was many steps ahead of the rest of Europe in this, and so I think that Katarina will be the ideal person to be talking to us about best practices using registries to improve quality of care and outcomes. Katarina, thanks so much.
Taking notes now of the very important presentation so far. Please, the next slide. I will share with you the experience from the Sweden and the Swedish National Diabetes Registry. This is first just a brief overview of the registry, which is on with both type 1 and type 2 diabetes patients. And today it's 100% of hospital outpatient clinics and 90% of primary healthcare units that are reporting to the registry. It started in 1996 for adults and then in 2000 for children. In line with the St. Vincent Declaration and by dedicated diabetes physicians and nurses. And since 2018, it's now one registry. Today, it's also funded by the health authorities and providers, and about 90% of all patients with diabetes are included, with a goal of at least one annual visit reported to the registry. The graph you see to the left does not indicate the number of rising patients in having diabetes in Sweden. It's the number of patients being reported to the registry. And today we have 420,000 adults and 8,000 children reported with diabetes visits 2020. So it's for this registry, all information comes from hospital and primary healthcare medical records, and about 70% are directly transferred, usually after every clinical visit, and about 30% are online registrations by nurses and physicians using the web page. And an important aspect is that it's always been very carefully selected clinically relevant variables that are based on guidelines. And whenever a variable have been added to the registry, it's in response to demands from clinicians. What will the clinicians use in their daily work? And since 2017, pilot units are also using our new Questionnaire, which collects patient-reported outcome and experience measures. So this is how you get the easy access to data. As a healthcare professional working with patients with diabetes, you have a secure login you can take the next. So it's a secure login for healthcare professionals so they can access their own unit individual patient data, and also that patient can log in to use to access their own personal data. It's just also important with interactive statistical reports that can benchmark with public results. So this is just an example of how we can use data in clinical practice. This is an example, and it's the easy access and group level data that I think is one of the important features that we have developed over the years. This is an application on the website, which we call Knappen, which is translated to the button. And if you click again, this is how you can choose different indicators of diabetes care. Here I show you an example of percentage of the proportion of patients using lipid-lowering medication. I have chosen hospital clinics, type 1 diabetes over the age of 45. And that is the first graph was the national level. And then we can see so there's a rise over the last couple of years. And the graph that Bart showed now is the regions. And we can see that it differs from around 40% to over 80%. And of course, there can be many explanations for this. It's like Professor Danne just said, that registry data, it always has to be interpreted with a background that we don't know for sure why the numbers are the way, but it is a difference here. And you can go one more. And that is when I go for Västra Götaland, which is my region, I can see how this proportion of lipid-lowering medication looks at the different hospitals in my region. And this is really and the next one, the thing is to analyze where is my unit here? Why are we in the middle? Are we treating our patients with lipid lowering the way we know that the scientific body of evidence now tells us, or are there reasons for why we're not? Next picture, please. So this is really how we use it. This is just a picture of how the diabetes teams are analyzing their own results. So the quality improvement on the ground is really with the work at the local level. So you have a systematic follow-up on your local results, even though you can access your own data through various health record systems as well. It's always the comparison to others, both regional and national, that all inspires. That is what SWEET shows, and that is what we can show as well, that it inspires the work at the local level. And then the team decides together where to start, where to make changes, and how to follow up. Next one. But it's also important that the authorities are in line with what the healthcare providers at the floor are doing. So there are indicators based from you will recognize them probably from your national audits, and so they're indicators based on guidelines. And in Sweden, the National Board of Health and Welfare, they have also set a target levels for some of the guidelines. And the next one. And this is also where the registry can help. This shows an overview of results from a primary compared to national results. And you see that if you have a yellow dot, that means you're in line with national average. The red dot would be that you're below, and a green one is above. And it's always also interesting to think that even though we in a couple of years ago had many green dots, knowing that other regions and areas in Sweden actually improved even more, we will now have more yellow dots. So it's not only the colors that are important, but it's the strive to improve as a group. We also present year reports that we distribute to healthcare professionals, to decision makers and other stakeholders, and they are discussed, and we try to distribute them in a manner that we have contact persons in the regions that discuss them at a local and regional level. And this is just an example of a graph that we had in our last report, proportion of patients with type 2 diabetes in primary care with different levels of LDL cholesterol in the regions. So, and what is the answer? Why some regions have a lower LDL proportion of patients with a low LDL, and why some regions have a higher? There can be many explanations, but the thing is to get the discussion in the teams and see what can be achieved to improve care and make it more for more patients to really reach the targets that we know are important in the long run. This is a very proud picture for the Swedish children's diabetes care, where some of them are in the SWEET project as well. But what we see from the start of the registry in year 2000 and now 2020, that the red part of very high risk HbA1c levels are actually getting smaller and smaller and smaller, which is very encouraging, whereas the green part with good glycemic control measured as in HbA1c is getting larger. So of course this is not, the registry is only a part of this, but it's the discussions, the teams working together with the children and with the parents. It's the access to insulin, of course, to technology, to the insulin pump, to the sensors. But it's not only the technology, could never be that, it's the whole team effort. Please, the next one. But even though HbA1c is clearly improving on a group level, we can still see that there are children that the time in target here with the 4 to 8 millimoles per liter, how much of the time do they have that target? It varies. So this is the glucose variability, and with a very high accessibility to sensors in Sweden, both with children and adults with type 1 diabetes, this will be a new target to see what we can help patients with. And there are also the register-based research, epidemiological research, that we can use research from the real world data based on patients in the register, and also that those results are presented both locally, regionally, and at national meetings. And I just have a few examples here. The importance of risk factor control, that we can use this in discussions with clinicians on our meetings, the importance of adherence, for instance, in type 2 diabetes to lipid lowering. And it was another study on the effect of flash glucose monitoring, for instance, just examples. Next one. We have the digital diabetes questionnaire to capture patient-reported outcome and experience measures. It's in pilot units at the moment. This will be incorporated in the registry. In the longer run, this will probably better be placed in the electronic health records and then with the data exported to the registry. But it's today a 33 question questionnaire with instant results. It's a digital instrument. We get the results as presented to the right, and that is something we can discuss at the visit, both how the person is feeling, general well-being, managing diabetes, and also how the person experienced support from diabetes care. Next one. So this hopefully can support patients both in raising questions with clinicians and become more involved in self-management. And the last picture. So these are just some reflections on how a register can contribute to improve quality and care and outcomes. So use clinical relevant data that clinicians recognize and are eager to look at and analyze. The easy access, both for the individual healthcare professional, the diabetes teams, but also decision makers, patient organizations, for instance, other stakeholders. It inspires discussions on how to improve benchmarking is very important to compare and to see not only that we are good and you are bad, but how are you accomplishing this in it's a very helpful way of looking at it. How can this team be better, just like Professor Danne told you just before? And also both the results from the registry and the registry-based research are also important. And I will also conclude with the patient involvement and the access for the patient to personal data in the register and to the diabetes questionnaire. Thank you.
Thank you very much indeed, Katarina. Great to hear all of that. Now I'm going to hand straight over to Chantal Mathieu, who's the chair of the EUDF, to take over some Q&A.
Thank you, David. And oh my gosh, how much information could we have registries and when it comes to doing something with the registries, and that is the person living with diabetes. So I want to ask Bastian Hauk, who is a director of the International Diabetes Federation Europe and also a leader of DDoC, to very briefly tell us how you, as a person living with diabetes, see how data and registries can really improve the life of people living with diabetes.
Chantal, thank you very much. And I can only echo what you just said. This has been amazing presentations on a whole range of issues around data, around registries, and how they can improve the lives of patients or of people living with diabetes, that is people like me and so many others here. So the first thing I want to say is that I really, really like how everybody seems to be in agreement here. And I heard the word patient involvement, user involvement so many times over this last hour and a half. This is really, the winds are changing, and this is great to see. I also want to see that from a user perspective, person perspective, patient perspective, all these benefits that have been mentioned, benefits for the healthcare system, benefits for HCPs, for doctors, for nurses, for, these are benefits that ultimately will benefit people like me in the end, because they're not just for the doctor or just for the healthcare system. So in the end, they will all lead to better medical outcomes, and this will benefit the lived experience of someone living with diabetes. But what I don't want to talk about today is anything related to the privacy issues, etc. around that. It is important. I'm not going to mention it here because we don't have the time for that. I think we want to really focus on benefits. What I want to talk about is the extra benefits of having access as a person living to the same data as the healthcare system, as the doctor or the nurse treating me. And I think this is super important. And I have seen this throughout these presentations, but really having access to the same kind of data that the person facing me in the doctor's office is so important. For me, dating many years back, can you remember when first CGM systems were coming to market? They were blinded for the person living with diabetes. It was only for the doctor to see. Can you remember that? I mean, how crazy was that? Because for me, it was the game changer altogether to see my own data every 5 minutes and see how that affected me. Now, that's a very granular aspect of looking at data. But also, I would really love to know more about, we've been hearing a lot from Robert Heine about costs involved. It's something that I find interesting as a person living with diabetes. How come that in Germany, at least, I don't have access to this data? I get my prescriptions, I get my medication and everything I need for free, but of course it does cost money. It would be interesting for me to know how much. I think that does make a difference. Going back to what also Robert Heine and Professor Danne said about data and data benefits, I think what is important is that the benefits that I ultimately have from as a person, also from secondary use of data, which is something very abstract to someone living with diabetes, these benefits have to become more tangible. I have to really feel and understand in very easy terms why this is important, because what we need to make sure of that is that people living with diabetes want to contribute, want to donate, want to generate this data in the first place. And this means it has to be very easy to upload data, to generate data, to donate data. And yes, I'm a big friend of consent forms, etc. But in the end, we also have to be sure that we don't make this too bureaucratic. I think I'll stop it here because we have very limited time and there's some amazing other speakers on the panel.
Excellent, Bastian. I heard many, many keywords like owning the data and impact. What does it mean for me? So another key stakeholder is the clinician. And here we invited a primary care doctor. How suitable can that be? Kamlesh, Professor Kunti is a professor of primary care in Leicester. And so Kamlesh, to you, I want to ask the question, what does it mean for you as a clinician, specifically a clinician in primary care, having access to data and registries?
First of all, thank you to the panel for invitations. Chantal, thanks very much for the introductions. So let's go back to the title of this meeting. It takes more than just a registry to improve care, which is completely true. Having data on its own doesn't do anything. So we've had data in the UK since 1984. It started in small number of practices. Now every practice is computerized. And Robert and Katrina gave really nice presentations to say what you need is integrated care models. So we have the data, but we need that interaction with the healthcare professional, with the person with diabetes, with the nurses. So in a primary care setting, I really can't function without my computer system now with the data. So when a patient comes in, I bring up the person with diabetes who's in front of me, straight away, it can prompt me when I bring the diabetes page up to say this person hasn't had their HbA1c checked in the last 12 months. This person's HbA1c is 8%. They've not had a blood pressure check done. And they're flagged up in red, amber, or green, depending on how you want them. If you want to flag it at 7% or above, I'll see the red signs straight away. I can concentrate on the areas that need filling in first. So this is what we use for our annual reviews or 3 monthly reviews when the patient comes in. We also have the computer systems. The data tells us a prescription. If we're giving a prescription to the patient, it tells us about the cost of that prescription. As soon as I enter the prescription, it tells me the cost of the prescription. Are there cheaper alternatives? That doesn't mean we're going for a cheaper drug, but there are companies making the similar drugs, and it can give me a therapeutic option that I can override it as well. The other thing it tells us is prescriptions. It tells me how many prescriptions the patient's picked up or when that patient picked up the prescription. So if our prescriptions are monthly and I see that they haven't picked it up for a couple of months, I can see that there may be an issue with adherence. So there's just so many facets to it. Finally, we can compare ourselves, what we call peer comparison feedback. I can compare myself to my peers in my region or nationally, and we get these data on a regular basis. So anyone, anywhere in the world, for example, can look at this data from England, sitting at home. So someone in India can look at my practice data, what my performance is in terms of HbA1c targets, blood pressure targets, lipid targets, whether I've done all the process measures, not by patient, but aggregated for the practice, and how I compare with other practices in the country. So it's very, very powerful. And finally, in view of time, one thing that really improved outcomes, particularly intermediate outcomes, and some of the harder intermediate outcomes, was pay for performance. In the UK, they took money away from primary care GP general practices, and they said, if you reach these performance targets, you get the funding back. And certainly, we know that right early on, there was improvements in care, but then we hit the ceiling, following which there hasn't been huge improvements. And like Robert showed the data, HbA1c improvements haven't occurred much, but we've seen huge improvements in blood pressure and lipid management. And I'll leave it at that. Thank you.
We've heard a lot about the importance of data registries for clinical care. We saw Sweden, we saw the example from Sweden, but data and registries are crucial, I would say, for research. And so I invite now Dr. Jeanette Soderberg, who is the Director of European Research at the JDRF, to give us your musings on the importance of data and registries for research, Jeanette.
I was going to say that the use of large data sets and registries provide enormous opportunities for diabetes research at very many different levels. However, it's not so much where we can use the data in diabetes for, but rather where do we need it? And there are so many questions that currently are still unanswered in research, where diabetes provides us with, where data provides us with a fantastic tool to answer these things in the long run. So the first, of course, is etiology of diabetes, where we're still not sure about the causes of developing the disease. And large cohorts such as the TEDdy study, where a large amount of longitudinal data has been collected by following kids from birth to adolescence. That could be one piece of the puzzle to answer questions around the disease mechanisms themselves and how things start. So that's an enormous large data set that we can utilize. Another example is, of course, what Leif Group and his team were doing, who used big data to classify adult onset diabetes, and they categorized it into 5 endotypes, going beyond type 1 and type 2 classification and describing how these different profiles have different progression of complications. And all of his work was completely data-driven, looking for patterns. The second area where we can use data is, of course, risk prediction and early detection of disease to allow us to come up with preventive interventions before someone actually develops diabetes. And if we can understand the risks and predict them at a very early stage, and then we have platforms such as EUDF, which is looking at finding new preventive therapies that stops the progression of the disease, then we've solved a big problem for type 1. But building these infrastructure, building these cohorts takes a lot of efforts. And that's something that we need desperately more infrastructure funding for, to be able to sustain and augment, because that data is needed. We should also, in this idea of risk prediction and detection, identifying complications early. This is a cost driving and a health, quality of life. I was going to say something that drives quality of life really in a bad direction is these fear of complications and complications themselves. And another example of how we have used data in complications research is machine learning technologies for analysis of eye scans and developing algorithms to identify very early signs of retinopathy that have become algorithms that are used in clinical practice. And I think that what you have in the data and the registries, everything that we do needs to look at data for personalized treatments. We need to be better at tailoring the care that we're offering to people with diabetes and make sure that what we offer them is suitable, sustainable, and is also what they need and want. And all of those aspects of data feed into what research wants to use it for, can use it for, and ultimately will give back to the patient. So it's kind of a circle, and we need to address all parts of it. I'll just raise one point before I'll be quiet, and it's looking for the future of data in research, which is that we need to think about more what type of data we have collected and where it comes from. So for instance, when we're looking at real-world evidence and data from devices, obviously that comes from people who have access and can afford the devices. And a lot of patients who report inpatient-reported outcomes, they are people of high health literacy. Data from clinical trials is often data from Caucasian men. And are we unconsciously introducing bias in our data sets? Do we need mitigation strategies to adopt to ensure that the data that we are using in our research to draw conclusions that we then apply to the community, is that representative of all people with diabetes? Because we don't want to create or increase disparities in diabetes health outcomes by using the wrong type of data in research. And my final point was just to echo something that was said earlier, which is that these new analysis techniques are capable of finding patterns in data, but the interpretation of these findings, that's further hypothesis-driven research that is needed. So it's data and research go hand in hand, and they're actually one and the same thing. So more data, more research. That's my conclusion.
Excellent, Jeanette. And I want to come to one of our partners also in the European Diabetes Forum. We have clinicians, we have people living with diabetes, we have research organizations, we also have industry. So I want to ask Maja Bujas-Bobanovic, who is the representative for the FPA Diabetes Platform and is working herself at Sanofi. How do you see the role of industry in data and registries, and how do you see industry contributing to data and registries? I cannot hear you, Maja. Is it me? Am I the only one not hearing, Maja?
No, we're not hearing.
No, I can't hear him either.
Okay.
Sorry.
So Maja, why don't you try and change your microphone, and I will jump over you then and go to, actually, at the moment there, Maja, I hear you. Yeah?
Okay. I don't know what happened. It is the same microphone. So thank you very much, Chantal. On behalf of industry, on behalf of FPA, I would like to focus on two key elements. First, building a consensus on how to generate, analyze, use, and share real-world data in a way that is valued and acceptable by all stakeholders. And the second one, partnership. I think we heard a lot about that. We can collect all the data in the world, but unless there is a strong collaboration between all stakeholders, and here I would like to add industry as well, we will not have the impact we want. We need to join forces and create long-term strategic partnerships if we want to improve patient outcomes. And as an industry representative, I would like to highlight our commitment to working together with all relevant stakeholders to make this happen. Over the years, we demonstrated our ability to generate high-quality data that secured approval of many new medicines and improved outcomes of many patients. So we believe that we are well placed to contribute to data set and system harmonization with best quality standards for data input and data organization. We heard a lot about that during today's symposium. We can contribute to data analysis, providing our data analytics expertise. We can help build big data ecosystem for more efficient insights and evidence generations. It's not only about one registry, but how to combine them. We can give access to our own databases from clinical studies, data coming from connected ecosystems, or from the pharmacovigilance databases that we have. How will we, industry, benefit from all of these discussions? Well, we know that randomized controlled trials are here to stay. They will remain the gold standard when evaluating the efficacy and safety of new drugs. However, we heard today just a few minutes before I spoke, when I started to speak, that we know very well that a large proportion of people with diabetes are not represented in these trials, as they fail to meet the strict inclusion criteria. For example, elderly, those with multiple comorbidities, those with very high A1C levels, and so on. So we believe that registries are necessary to complement the results of randomized controlled trials and provide additional insights on effectiveness and safety of our medicines in real-life clinical practice. Registries are useful for many other things, and we heard today how we can better understand disease burden, diabetes management overall, and this is all very helpful to us as well. To identify unmet needs, where are the areas that we can best intervene as the industry. Last point, a few years ago, health authorities have also recognized real-world evidence as a complementary evidence used for regulatory decision-making. I don't think we spoke a lot about this during today's symposium. We can see more and more examples where real-world evidence was used in regulatory approval of new indications or in fulfilling post-marketing safety commitments. And quite often, because of the quality or lack of quality of real-world evidence data or missing information, we are not able to pursue this path. And so to summarize from the industry point of view, all these points will result in faster drug development and approval and will improve the value of our medicines for patients, providers, and society. Thank you very much for the opportunity to comment.
Thank you, Maya, for this very open view on data and registries. And we've already heard about the European health data space from André Rich, saying what is in the heads of the European Commission, but there's also the European Parliament really driving policy. So the final person I want to call into this discussion is Mr. Tomislav Sokol, who is a member of Parliament and a proud member of the European Parliament Mobilizing for Diabetes, our MEP members, a project that we as European Diabetes Forum and IDF have very close to our heart. Tomislav, I also saw you have a PhD in Leuven, which is very, very good. But so what is Europe's view on data, the importance of data, and how do you see the role of the European Parliament?
Thank you very much. I would first like to thank you for inviting me to speak about this very important topic. And the figures and the numbers just speak for themselves. So 1 out of 10 Europeans have diabetes, and there is an estimate that if they do not do anything about it, that by 2045, 80 million Europeans will have diabetes. So this is one of the biggest public health problems in Europe, and it's something we have to discuss. And when you mentioned my PhD in Leuven, actually, I'm a lawyer. I'm not a medical healthcare professional, but I did my PhD on cross-border healthcare and free movement of healthcare services in the EU. So EU health policy and health law have been in the focus of my work for the last decade or so. So when we speak about European Union and European Parliament, the first thing that, of course, needs to be said that, as you probably all know, EU has very limited competences in this field, and so we cannot do everything that we want. For instance, we cannot legally harmonize healthcare standards. So this is something that cannot be done on European level. Rather we can support and help member states in achieving healthcare objectives that they have stated. But what is important is that this limitation of competences is not an excuse not to do anything anymore, because the COVID-19 pandemic has shown us that in many areas, EU can provide this added value and resolve issues that member states cannot resolve by themselves. And healthcare is precisely one of those areas, and the use of data in the area of healthcare is one of those areas where EU can and I believe will provide the added value. So when we speak about concrete action, of course, we share most of the points raised by the Commission. And of course, we in the Parliament are kind of dependent on the Commission because the Commission has the sole right of legislative initiative. So we as Parliament cannot propose new legislation by ourselves. Rather, we have to wait for the Commission to make a proposal, and then we use what we can in terms of amendments, in terms of changing what we think needs to be changed. And in the end, we and the Council, the member states in the Council, need to reach an agreement on this EU legislation. So what we are definitely eagerly waiting for from the Commission is a new regulation on EU health data space. So this obviously is the big topic today. It was already mentioned, and this is definitely the crucial piece of legislation that we'll be working on. Because, as I said, we cannot harmonize healthcare standards, but we can remove obstacles that exist. And of course, the biggest obstacles that exist currently is the lack of interoperability between data between different member states. And this lack of interoperability of data, of course, affects cross-border research, cross-border clinical trials, use of the European reference networks, which are founded by the European Union, by the directive on cross-border healthcare. So all of these issues need to be resolved. This cross-border, and of course, in this area, European Union has the competence because these are cross-border issues, and the European Union can and will do what it can to remove obstacles to this cross-border use of data. And this is the biggest added value that EU health data space new regulation, which will be presented by the Commission, can do. And in the Parliament, there is a strong push and strong support to resolve all of these issues and to really have this common European health data space where we can have cross-border clinical trials, cross-border research, use of European reference networks, use of telemedicine, use of European patient health records, so that all of this can use in different member states. And this is one of the most important pillars also of the European Health Union that we are currently working on, because we cannot have European Health Union without this common health data space. So this is the most important initiative, but it's not the only initiative that European Union can work on. So apart from regulatory framework, the rules like European health data space, which aim to remove the obstacles for use of data between member states, we have a lot of financing at our disposal. And I would like to mention here that we were able to approve, and this was on insistence of the Parliament, the new EU for Health program, which is 12 times bigger, the budgetary program, which is 12 times bigger, has 12 times bigger resources than the previous health program of the European Union in the previous 7-year period. So currently we have 5.1 billion euros at our disposal in this EU for Health program, and this can be used to finance healthcare research on diabetes, to the prevention programs, monitoring, surveillance, and also obviously the development of common European registry. So we have this area, so we have these resources at our disposal, and I think that we on the European level can do a lot in terms of both regulatory action and financing to really enable this use of data and to create one common European registry, which will be beneficial for both for patients and industry as well. And my last point that I wanted to make, what is important is that we have to change this idea of healthcare investment as a cost. And this is what we are strongly working on in the Parliament, because this is not a cost, this is an investment. Because I have data that around 148 billion euros is the cost, annual cost of diabetes in terms of, and this directly influences the working performance of people who are in employment or self-employed, and this definitely negatively affects European economy as well. So trying to shift this perception of healthcare investment of healthcare funding as a cost and to change it more into investment is something that we will definitely work on in this mandate, and also I believe in the next period. So to sum up, we are deeply committed to enable use of data, cross-border use of data, clinical trials and research in European reference networks, telemedicines, etc. We are strongly supporting this. We are putting the pressure on the Commission to come up with a concrete legislative proposal, and then I believe with our amendments that we will also be able to improve this proposal and to make this European health data space a reality for diabetes patients as well, but also to use the funding that we have at our disposal to develop registries, to develop prevention also from diabetes, and to really help member states achieve the goals of reducing the number of cases of diabetes in the future period. So the European Parliament is definitely a very strong advocate of this, and it will have our full support in the years to come. Thank you very much.
Excellent. So if I may have all speakers who are present to turn on their cameras, because we heard Robert a lot. I think everybody who spoke clearly indicated that registries have added value. You need to know your enemy in order to make any decisions, but everybody said they're not enough. You need to do something on top of it. You need to have quality circles to improve your care with the data that you find in the registries. Another very important message you gave was you need to have the buy-in of all stakeholders? Well, I think we heard clinicians, we heard people living with diabetes, we heard industry saying, we support this. So there is buy-in, but there were some very interesting remarks also in the questions. For instance, the fact that you shouldn't have silos, but that you shouldn't reinvent registries, but try and harmonize them. There were some suggestions to use a specific system. So I think most people are welcoming the European health data space. The louder voice, Robert, I think we had some very loud voices. The two registries showed the data. How loud can your voice be? Sweden, impressive that if you have the data and you build on them, you go forward. But there was also in the Q&A a remark that you should also include, for instance, patient-related outcomes in all of the registries. That is also important, not only hemoglobin A1C. And so there was some great support for Sweden to have these things there. And then, yeah, integration of all of these registries. So can I ask you, Robert, to make the integration of all the presentations of the panel members, and then what you've heard this afternoon, and see how this fits into the working of your strategic forum?
Well, thank you so much, Chantal, for the opportunity, and you summarized it quite well. So my interpretation of what we heard today is that we are still in the observational phase. I spoke with Thomas about it as well. If you look at motivated pediatricians who are really setting ambitious targets, they will achieve better outcome than pediatricians who didn't sign up for the registry. So there's a voluntary base. Katrina also mentioned this. It really depends almost on your postal code, what kind of quality of care you receive as a person with diabetes. I think it's completely unacceptable. So why are we still silent about it? So the observational studies or the registries have taught us a lot about the quality, the lack of improvement in the quality in major regions globally. So I think we really need to move forward to the intervention phase. And that's why I highlighted what happened in Hong Kong. Let's use these data also for accountability. No one mentioned really, well, I did it in my presentation, but no one maybe dares to say, well, let's use the word accountability.
Yeah, I'm looking at the time because they will kick us out of Athens. But by raising your voice, I think you also confirm to Mr. Sokol and all the other policymakers that diabetes should be on the agenda.
Definitely more than that, yes.
Oh.
It's really time for action now.
David, you have 20 seconds to wrap up.
I do, and I'll use these 20 seconds to say thank you very much indeed to all of you for a wonderful meeting. I've been fascinated by what we've had to say, and I look forward to seeing you many times in the future, and thank you for a wonderful session. And in the last 2 seconds, I shall just say goodbye.
Goodbye, and thank you.